Thank you so much, ma'am, for your valuable insight. Coming to the next, I would like to call upon the stage Dr. Anil Kumar, sir. Sir has served as the president of the Association of Physicians of Ahmedabad and has been actively involved in academic leadership and advisory across the country. Welcome, sir.
So I've been asked to speak on intersection of obesity, diabetes and heart failure. So just 4 decades ago, the prevalence rate of obesity in most high income countries was less than 5 to 10%. Consequently, rates of myocardial infarction and stroke were substantially higher, and most patients diagnosed with heart failure had a short life expectancy, many succumbing to disease-related cachexia. Today, the prevalence of obesity is now more than 25% to 40% because of calorie-rich food with poor nutritional content and more sedentary lifestyle. This new dawn of obesity means greater aggregated exposure to excess adiposity, its multiple consequences and accelerated multi-morbidity. For last 2-3 days, we are all listening to this only. So I will just, in the interest of time, I'll skip. Obesity and heart failure prevalence have increased globally. Current heart failure prevalence is estimated to be 64.34 million cases, accounting for 9.91 million year loss due to disability. Worldwide, 64.3 million people are estimated to suffer from heart failure in 2017, making it a global pandemic. That was in 2017, I think. Data is old. I think nowadays we must be having around 90 to 100 million people which are suffering from heart failure. So WHO defines obesity and overweight as an abnormal or excessive fat accumulation to the extent that health may be impaired. Approximately half of the patients with heart failure have a reduced left ventricular ejection fraction or systolic dysfunction, while the remaining half present with preserved left ventricular ejection fraction, that is heart failure with preserved ejection fraction, usually characterized by presence of diastolic dysfunction, also known as diastolic heart failure. The risk of heart failure increases in a linear fashion with increasing BMI, and persons with obesity, defined as BMI more than 30 kg per meter square, are at particularly elevated risk for heart failure for preserved ejection fraction. So, in addition to being associated with worse functional status and symptom burden among patients with heart failure, obesity is also associated with a higher risk of hospitalization for heart failure in persons with both heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. So, as we know that hospitalization for heart failure, it is also most of the study, it is also an endpoint nowadays. So, epidemiology and obesity of in epidemiological studies, there is powerful dose-response relationship between adiposity and heart failure risk. Among older adults, 60 to 79 years, the cumulative incidence of heart failure for normal weight, overweight, class 1 to 2 obesity and class 3 obesity are 8.9%, 11.1% and 16%, and 29.2% among men and 5.4, 6.6, 11.4 and 21.4 among women. Although the survival rate in patients with heart failure has improved in recent history, the death rate remains very high. More than 30% of the patients die within 5 years of an heart failure diagnosis. So obesity increases the risk of heart failure. So this is the pathophysiological mechanism. So basically, because I don't have a pointer, excessive fat accumulation in visceral adipose tissue and ectopic sites such as pericardium, epicardium and liver results in higher circulating blood volume and local and systematic pathogenic inflammatory factors which acts to increase stroke volume, cardiac wall stress and myocardial injury, leading to concentric left ventricular hypertrophy, left ventricular remodeling and ultimately diastolic and systolic cardiac failure. So
इसको क्लिक करने से एक आ जाता है ये सॉरी आई गेट बैक टू द ओल्ड वन यहाँ से आप ये देखिए
yes, thank you sir. So Proposed etiology of heart failure with preserved ejection fraction is relevant to obesity and type 2 diabetes. Coronary microvascular inflammation is now postulated to play the key role in heart failure with preserved ejection fraction progression, encompassing endothelial dysfunction and impaired nitric oxide, CGMP, protein kinase, signaling and increased collagen deposition. So you can see as here, yes, here this ROS and decrease NO, it results in increased inflammation, endothelial dysfunction and capillary rarefaction, and it results in decreased PKG, which results in stiffness, hypertrophy, collagen disorder, and then this fibroblast activation results in interstitial and perivascular reactive fibrosis, and then it results in impaired vasodilation as well as impaired vasoconstriction. The hyperglycemia, insulin resistance and hyperinsulinemia that often accompany diabetes mellitus triggers a cascade of deleterious effects that contribute to the development of heart failure in diabetes mellitus. So you can see this. This diabetes results in hyperglycemia, insulin resistance, hyperinsulinemia. Then it causes inflammation, dyslipidemia, endothelial dysfunction, which results in coronary artery disease, and it results in ischemic cardiomyopathy. At the same time, cardiomyocyte hypertrophy, RAS activation, in calcium handling, fatty acid utilization, formation of AGE results in fibrosis and autonomic dysfunction. These all results in diabetic cardiomyopathy. And this ischemic cardiomyopathy and diabetic cardiomyopathy results in heart failure in diabetes. So, adipogenesis modulates the AT remodeling process, and hypoxia is the trigger behind angiogenesis, extracellular matrix remodeling and inflammation. Low-grade systemic inflammation versus cardiovascular diseases. It triggers as endothelial inflammatory response in the coronary vasculature. Lastly, microvascular rarefaction and sirtuin SIRT3 dependent defect in the endothelial cell results in metabolic programming, and angiogenesis may affect the progression of perivascular myocardial fibrosis and heart failure with preserved ejection fraction. So now coming to the management, the association between obesity, weight and heart failure are like this. Obesity and risk of hypertension. Yes. Obesity of risk of hypertension, heart failure, higher BMI associated with the stepwise increase in risk of future heart failure. Risk of heart failure, preserved ejection fraction is particularly high among patients with obesity. Obesity and heart failure as comorbidity. Patients with obesity have higher rates of heart failure hospitalization, higher symptom burden, and lower quality of life. The relationship between obesity and death is unclear. Weight loss and risk of heart failure. Weight loss, especially via bariatric surgery, is associated with lower rates of incident heart failure. Weight loss in patients with heart failure is associated with improved symptom burden in patients with heart failure, preserved ejection fraction. Ongoing trials will help to establish the impact of weight loss and clinical outcomes. So, obesity approach to the management of overweight and obesity in patients with established heart failure. Overweight with heart failure, BMI between 25 to 29.9 kg per meter. Heart failure, preserved ejection fraction or reduced ejection fraction, no evidence that weight loss is beneficial, although a healthy lifestyle is encouraged. In obesity class 1, individualized lifestyle and anti-obesity option based on heart failure stability, functional status and cardiometabolic morbidity, patient preferences. In obesity class 2 to 3 plus heart failure, in that BMI is more than 35, obesity treatment can be considered, although the patient selection for GLP-1 agonist or surgery require further study. Weight loss is the first therapeutic goal that should be achieved in obese heart failure patient. Then obesity, semaglutide mediated weight loss is a valuable intervention for improving functional capacity, quality of life and heart failure stability for patients with the obesity, heart failure, preserved ejection fraction phenotype. So this we are listening for last 2 days about this. So obesity treatment, again lifestyle is the main. RCT, like look ahead, Dr. Abhichandani talked about it, other people also talked about it. 20% reduction in incident heart failure with 4 year 10% BMI decrease. Then medication RCT select, that is semaglutide, 18% reduction in heart failure composite with 104 week 8.5% weight loss. And surgery, bariatric surgery, that is Venote and all 2017 retrospective cohort study, there is 62% reduction in incident heart failure with 5-year 30% BMI decrease. So with heart failure, preserved ejection fraction, RCT secret hypocaloric diet plus exercise, 10% weight loss at 20 weeks, while in this 8.1% BMI decrease at 24 weeks, step trial again semaglutide, 10.7% weight loss at 52 weeks, improved symptom functional capacity. The latest 2022 review of heart failure guideline by American College of Cardiology and the AHA 2021 heart failure review by the European Society of Cardiology recommended weight loss to prevent heart failure, that is preserved ejection fraction. Still, they do not recommend weight loss in obese patients with established heart failure due to lack of large-scale studies examining the safety or efficacy of weight loss with diet, exercise or bariatric surgery. So, lifestyle modification are suggested by both. Salt restriction, again, avoid in stage C heart failure. ESC said avoid more than 5 grams per day. Specific diet, Mediterranean and DASH. European, they do not advise any. Fruit restriction is required in AHA-ACC guideline. Again, the ESC also says weight loss. Again, it is not recommended in AHA-ACC guideline. While European says a pre-heart failure transplant BMI should be less than 35 kg per meter square. Exercise, cardiac rehabilitation is advised by AHA-ACC, and ESC says again regular exercise. So, pharmacological management, again, these are the old drugs, bupivacaine, naloxone, body weight reduction up to 5%, GLP-R1, greater reduction body weight more than 10.7% compared with placebo, reduction of composite outcome of death from cardiovascular causes, non-fatal MI or non-fatal stroke in secondary prevention. Tirzepatide, again, sustained weight reduction in obese adults up to 24%. And retatrutide, body weight reduction up to 17.5% at 24 weeks. In the last few years, effective pharmacological therapy with a better efficacy, safety profile have been introduced in clinical practice to target obesity and diabetes. Some of the medications have also shown beneficial effect in heart failure. The modern, so obesity, role of GLP-1 RAS, effect on, it has been talked in last 2 days again. So weight loss benefits in obese patients. So heart failure preserved with diabetes, role of GLP-1 same. This is the mechanism which have been deliberated by many speakers before me. So I will skip this also. Role of SGLT2, the effects of SGLT2 according to their hemodynamic and metabolic actions are summarized in the figure. Collectively, these mechanisms synergistically and positively affect kidney and heart outcome. Furthermore, cardio-renal interactions that lead to virtuous cycle are linked to a favorable outcome. The overall effect of SGLT2 appears to be similar between obese and non-obese individuals with heart failure with preserved ejection fraction. Potential targets of approach of heart failure with preserved ejection fraction and obesity, again exercise and lifestyle modification, aerobic exercise training, reduced calorie intake, NO enhancement or replenishment, nitroxyl donors, inorganic nitrates, beta-3 adrenergic receptor agonist, and SGC stimulators, endothelial cell mineralocorticosteroid receptor signal, spironolactone, non-coding RNAs, that is NGOME, RS, glucose-lowering drugs, metformin, GLP-1 receptor agonist, SGLT2 inhibitors, novel approaches enhancing protective gluconolyl cyclase system, that is LCZ, 696 and PD9 inhibitors, and independent of cyclic GMPs, pro-NP. So again, the HbA1c goals, again, this is according to the status of the heart failure. So if we expect long life expectancy, then it should be maintained around 6.5. If it is limited life expectancy, then we can maintain around 8%. These are the landmark trials linking obesity, diabetes, and heart failure. These have been talked about by previous speakers again. So higher BMI, weight circumference, and FM are strongly associated with greater risk of heart failure among the older adults, particularly among those with prevalent diabetes. So this is delivered trial. Obesity is very common in contemporary patients with heart failure with preserved ejection fraction. The efficacy and safety of dapagliflozin is consistent across the spectrum of BMI, with substantial absolute benefits in patients with obesity.
So we can move to the summary slide, please, sir.
Yeah, okay. Then this again, step, okay. Obesity-related heart failure is increasing globally. Overweight and obesity represent major risk factors for both heart failure reduced ejection fraction and heart failure preserved ejection fraction. However, specifically for heart failure preserved ejection fraction, the obese type 2 diabetes phenotype has distinct pathophysiology encompassing inflammation, CMD, and LV remodeling. A complex interplay is seen between obesity, type 2 diabetes, and heart failure with preserved ejection fraction. Weight loss is the first therapeutic goal that should be achieved in obese, type 2 diabetes, mellitus, and heart failure patients. Evidence exists to support the inclusion of GLP-1 analog in the AHA-guided directed medical therapy for heart failure preserved ejection fraction, which could significantly augment the therapeutic landscape for obese, type 2 diabetes, mellitus, and heart failure preserved ejection fraction patients. Landmark trials of semaglutide and tirzepatide confirm their efficacy in patients with obesity, heart failure preserved ejection fraction phenotypes, and in type 2 diabetes mellitus patients. Anti-diabetic agents like semaglutide and SGLT2 hold promise as a useful adjunct agent for obese, type 2 diabetes, heart failure preserved ejection fraction, and should be studied in randomized clinical trials. Thank you, sir.
Thank you. Thank you for the wonderful lecture, sir. Thank you.
Thank you.
Thank you so much, sir, for the valuable information and the knowledge you shared with us. And thank you also to our chairperson, sir,